Hello and welcome to the Healthcare Today podcast. Our guest today is Ian Wharton, the founder and CEO of Aide Health, an AI-driven health technology company helping to enable patient self-management. Following a 20-plus year career focusing on design and innovation, Ian places the duty of care on those living with chronic conditions and uses Aide's products to help manage their health. Today, Ian makes a compelling argument that the future of healthcare lies not in more appointments, but in supporting the 99% of life that happens between them. So you've previously stated that healthcare cannot scale through appointments alone. Was there a particular experience that crystallized this belief for you?
It was certainly a belief we held when we started our company, which was 5 years ago now, 5 years in January. It was certainly one of the reasons we decided to do what we do, coming out of the experience in the industry we had been in previously. It's definitely crystallized. Now we've been working with the NHS and its organizations for 3.5 of those 5 years. You just hear the stories, you see the challenges, you see it on the faces. And there's lots of evidence on this. To deliver guideline recommended chronic disease care requires about 10 minutes per condition per patient. So when you consider that comorbidity is the norm, so 1 in 3 adults globally have 2 or more conditions, you just get impossible maths. And that's further compounded by the projected workforce shortage, which I think give or take is about 300,000 clinicians over the next 9 or 10 years. So that's definitely one part of it. But it's worth saying we launched Aide Health from a perspective of lived experience. So myself and my co-founder, Brian Snyder, we aren't clinicians, we're product people, essentially. I'm a designer principally. We've both spent 20 plus years in the design and innovation world, building digital products and services, either in startups we founded or for the Fortune 500. But like so many, we have also lived through brief episodic encounters of chronic disease care, which means the bit in the middle is the challenge. So it misses the education, it misses the medication support, misses the day-to-day. I should be clear that this is what we don't intend to say is this is a rejection of clinical care. It's simply a recognition that the model has this built-in ceiling of capacity. There is this hard limit on all of this that needs some kind of solution.
Can you paint a picture of what hitting that hard limit looks like from the perspective of a patient, a GP, and the system as a whole?
There's probably nothing revelatory here for your listeners. I think they would recognize all of this. So we can speak to the patient first. We're a patient-facing company. What it means and what it looks like is you're waiting weeks to be seen. I'm generalizing across the country as an average. Like, to give you an example, the GP practice in my hometown here in South Oxfordshire, amazing, especially if it's something to do with our child. He's seen the same day. But broadly speaking, it looks like long waiting lists and complications as a result of that. It means getting minutes with your clinician to cover complex, high-stakes health information. It means challenges of continuity of care, continuity of information, being given instructions you just don't remember when you walk out the room, and kind of being left on your own until the next appointment, that's probably the bit to underline. If you're left on your own for the majority of your healthcare, you get isolation, worry, uncertainty, poor outcomes. So that's the patient part. For the GP, your audience probably know this better than I will, but it looks like consultations that should take 30 minutes, 40 minutes, compressed into 10. They have to make a call on what gets deprioritized, which is probably the education bit. You can ask, well, why does that matter? But if you took just one simple thing, good example. So if you like people living with asthma, inhaler technique, right? So inhaler technique's a good indicator here. So I think it's fair to say most clinicians don't have the time to deliver guideline recommended inhaler technique to their total population. Well, from what we understand, a quarter of the people don't demonstrate correct inhaler technique. So what does that look like across an entire system? It looks like exacerbations and people visiting the A&E. That's one example of thousands, I suppose. And then for the system, articles I see on your site all the time, it looks like preventable deterioration that becomes acute. It looks like patient populations that largely can't self-manage, even if they want to. And then the system absorbs those failures downstream through A&E admissions and high costs. So again, this is not a reflection of clinical quality. It's a structural limitation, but like we should be pretty clear. This is a predictable cycle and one that's changeable.
Now, you've previously said that more than 80% of long-term condition care is self-management, as you just spoke to. If this is already the reality, why do you think health systems have been so slow to build around it intentionally rather than treating it as an add-on?
This is a really compelling question. I think it's perhaps reasonable to say that self-management may be at large is seen as second best care, is like maybe it's seen as something that happens in the absence of the real thing, which it just isn't. All the evidence shows the opposite of that. Like patient engagement programs, digital or otherwise, have lots of great quality of life improvements and return on investment indicators. Another reason I guess you could argue is how systems are measured. We measure what happens inside clinics, right? So the NHS is pretty good at revealing that data. We measure how many appointments are delivered, what referral to treatment targets might be. What we don't systematically measure is what happens in between appointment. And that's a philosophical shift. It means shifting from the clinician being the primary actor in a patient's health to the patient being the primary actor. We love this phrase. It came from, I believe it was Don Kemper, who was the founder of HealthWise in the US, but it has been echoed here in the NHS by Sir Muir Gray and a handful of others, which is the patient remains the greatest underused resource in care. And that's something we're certainly trying to help rectify. But I guess the simple thing here is that all incentives are oriented around provider-led care. And as the saying goes, you show me the incentive, I'll show the outcome. So, but there's something spiritual here, there's something philosophical that would need to change, I think.
Obviously, you used the example previously of inhalers misuse and the subject of patient education. Is this a failure of patient education, or is it a fundamental flaw in the care model that assumes that with stretched resources that one conversation is enough?
You could argue both if we're being fair. So in some cases it's not a reflection on patient capability. I think if we had a sober conversation with ourselves as people in healthcare, like on the front line or otherwise, what the patient essentially gets is time-pressured conversations with complex, sometimes quite frightening language. And someone even with all faculties, with it on a good day, I would struggle with that on a good day. And all the evidence shows 40 to 80% of information is forgotten when you leave the room. Now, in some instances, it is more difficult for the patient themselves, where it's not solely on the system. So recall of health information disproportionately affects people with dementia, with complex needs, with things like dyslexia. And we wrote about this in our white paper, there's 43% of adults in England can't understand health information. That rises to around 60%, just over, when any numerical information is included within that. So there's lots of different reasons, as with everything in healthcare, that it's always so multifactorial. I guess either way, the important thing to say is what we get is unfair differences in care. That is, you get higher anxiety, poorer outcomes, and a whole host of other things downstream. All things are solvable. I mean, so this specific issue is one of the reasons we launched our second product of October last year, called Mirror, which is, I mean, it's like very straightforward, really. It's a patient-facing scribe. It captures your consultation for you and summarizes it for you as a patient. Now, there's loads of clinical scribes, and we just thought, well, it's kind of missing the most important part here, which is the patient themselves and how they act on the information they're given. But as with everything, it's a bit of a mix. Wouldn't be fair to put it on either the patient or the system.
Digital self-management tools are powerful, but they do risk leaving behind those who are not digitally literate or lack access to digital tools. How do we ensure that scaling care through technology doesn't actually help to widen the health inequality gap?
I think this is a fair concern. I think it's a legitimate concern to take seriously. We do hear this. In kind of commissioning or deployment conversations, we do get a flavor of this. Now, I would always naturally challenge the assumption that digital tools inherently exclude. That being said, it's worth addressing the fact that no system, whether it's digital or physical, will work for everyone all of the time. I mean, let's face it, if we could magic our way to give everyone in this country their own private clinician that only helps them, I mean, there would still be people who wouldn't adopt it and exercise the value of that, or would struggle with it in some ways. That, by the way, that is actually sometimes the expectation of the conversations we have, which is, I mean, even though we support 6 conditions today in our flagship product, Aide, which is our chronic disease management platform, soon to be 9 conditions with these 3 hematological cancers that are coming out soon. Even still, we get questions of, oh, this sounds great, but can it also do this and also this? And would it be any chance we could also solve this problem over here? So there is this kind of expectation that it should do one thing for everything and solve every challenge, which is not a reality. So that being said, I can speak from our data. So we have patients in their 80s using Aide. That's our flagship product. We have people in areas of deprivation using our product. So we capture the first part of a patient's postcode when they onboard to our product, and we can run area classification on that partial postcode. So we know for a fact we have people using Aide in areas of hardship, aging, outer city hardship, and a whole host of other things. And we also know that on average, patients are interacting with Aide 4 times a day. So what that means for us, our platform is based on conversational AI. It has short conversations, quite often that are daily, to help patients manage their medicine, track their health, and improve their health literacy. But on average, 4 conversations per day are being had across our population. Now, we still see, is this fair to say? I think it's still fair to say that we still see a lot of studies on digital interventions that exclude those groups ahead of time. So we'll see studies that go up to 65 and not below. We've always, maybe out of naivety, we've always seen that as an unnecessary limitation. We've never had that. We have a lower age cap, so 18 plus. We don't support children today, might in the future, but we've never had an upper age cap. So yes, there are absolutely groups where digital tools do not work, but there would also be groups where any other tool wouldn't work. We should also be honest about the system as it is today. It already excludes through different mechanisms, right? So we have physical mobility requirements prevent mostly housebound patients from attending appointments. I have people in my family who would fall into that category. People with complex polypharmacy, that is not supported day to day because it's, so I'll give you an example here. So the patient managing the most medicines in Aide is managing 19 medicines. Now, those 19 medicines have not come from one discipline or one clinician. So how would support ever be given to that patient? We have health literacy barriers, and then as we mentioned, the risk of forgotten information. So I guess the short way of wrapping that question up, well-designed digital tools can improve access, in our belief. They won't solve every challenge, but they are infinitely scalable, which traditional healthcare is not.
A year-long partnership between Aide Health and 7 Suffolk primary care GP practices supported adult asthma patients through digital self-management. The results reveal that 72% patient retention after 30 days, that's around 20 times the sector average, as well as a 73% medication adherence. Can we talk a little bit about what were the key design principles behind the digital support that you think drove such high engagement?
Retention is the challenge of digital health. It's I don't know if it's still kind of like a poor cousin of what people talk about as the challenge. Like the challenge for companies like us, it's not regulation that's manageable and with a bit of money and effort you can get through that. It's not distribution, it's not integration. All those things are solvable. It's retention. There is a huge promise of digital health tools as long as patients use them, and the reality is they just don't. So as you mentioned, the average 30-day retention rate, which means patients still use that platform after 30 days, is somewhere between 3.5% and 4% of people. So we're somewhere between 60, kind of low 70% of people still using it after 30 days. We've had a small number of patients use Aide for 2 years now, more or less every single day. Some of those patients have heart failure and are quite dependent on it. We still have a ton of work to do. We don't think we've cracked it, by the way. But I guess the big difference is, as a design-led health technology company, we make certain decisions that others might not. And we're quite rare in that fact. Like there aren't many health technology companies with essentially product or design founders. So I guess the first one is we involve the patient. It's like some people will just laugh at maybe that statement and think, well, what else would you do? But you'd be surprised. So we've run hundreds of hours of patient workshops at this point to understand the need of the patient and what they would do if they could wave a magic wand and what their real challenges are and what are the unspoken challenges and all sorts of other things. 2, we use conversational AI. So we made that bet 5 years ago. It was the only way we thought we could address the challenge individually in a way that scales. And what that means is we've designed the tone. So we speak to the patient like Aide is theirs. You don't feel like you're one of many. You've got ownership of it. So that it probably drives retention a little bit. I think thirdly, the breadth of the product. So we've built Aide on the shoulders of a 2-decade, 15-year health technology sector that's made a load of successes and failures that we can learn from. Adherence-only apps are pure utility, so they kind of miss the bigger picture. Education-only apps don't support the day-to-day. Tracking-only apps don't educate beyond the digits, and sometimes those digits can be frightening. You need to do all of those things and do them well. And I'm not saying we have cracked that yet, but it's something that we're working towards, certainly, is to deliver that breadth.
You focus on asthma for this pilot. How transferable is this model to other long-term conditions like diabetes, heart disease, or even mental health?
So in our view, highly transferable. So we, again, speak from our own data, we support 6 chronic conditions. So asthma, type 2 diabetes, hypertension, COPD, chronic kidney disease, and most recently obesity. The only pathway we don't yet have enough data on is obesity, but what we see similar patterns across all of them. Now, our focus from the very beginning has been comorbidity. That's the underserved issue. We don't have a pathway for mental health. We probably never will. We think that is a certain specialism that requires full attention. I think a good mental health service would pair well with something like Aide, but we don't do that. So we have no first-hand data there. My view would be that outcomes are very possible. There's some great companies that show that here in the UK. We have companies like MindStep or Limbic. They're doing really great work. I think the only caveat here is what patients do not need are tools that match system fragmentation. So patients cannot manage 3, 4, 5 different apps for 3, 4, 5 different conditions. We've never once heard that. What patients want is holistic care. Really tough to do, but possible. So yeah, I would argue highly transferable.
If digital tools handle education, reinforcement, and monitoring, how, to your mind, does the role of the doctor or nurse change?
We've always been fans, because of the clinicians we work with, in particular Dr. Stephen Leitner, who's been with us since day one, actually. We've always pushed for supporting shared decision-making. It's a really good model for co-owned care and does help put the patient as a primary actor in their care. So I would argue tools like Aide Health would facilitate that. Clinicians have more insight and therefore they can have more informed conversations. Just to give an example, a big discussion here is patient willingness to confide in clinicians. So there's a lot of evidence to show that around 70% of patients withhold information that would otherwise be medically relevant because they fear being judged or letting down their clinician. That withholding of information undermines care. So if through tools like Aide, you disclose more information that would otherwise be uncomfortable in the moment, well, that's medically relevant information that can support and enhance care. So that's definitely one part of it. Efficiency off the back of that. So clinicians focusing on the patients that need urgent attention and they aren't delivering, 1,000 hours of asthma inhaler technique every year. That can definitely be done asynchronously through good technology. And then probably the facilitation of other things like more peer support, better group consultations, and so on. But really for us, it's 2 crucial things. Not replacing the clinician, that is not our goal. And I think good digital tools should never have that goal. But also getting insight and information that is otherwise really, really hard to come by. So it's a better relationship.
With Aide, you're advocating for a new care paradigm. What's one piece of advice you would give to NHS trusts to start making this shift without them having to wait for a massive technology overhaul?
There's a handful of things come to mind. It's somewhat unfair because, again, we know the pressures, we know the limit of resources. That being said, we also see just some outstanding forward-thinking clinicians in the NHS. Dr. Yasmin Razak in London, Goulburn Medical as an example. There are people like her who are deploying technology and measuring their impact effectively in a community, and they're doing it really well. So I think there's probably one misstep that we see primary care networks or ICBs making with technology, which is not deploying them at a sufficiently large scale. So I think it's one of the most common mistakes is running small pilots of 20 to 30 people of a digital tool that won't generate statistical significance or operational learning. So they need to be deployed at a sufficient scale, but there has to be a step before that, which is the regulatory bit, the safety bit. But most of our peers in the health technology sector in the UK are there. What they need to make the next step to save companies like ours going, you know what, we're going to turn our attention to the US, which breaks my heart. And it's not why we started the company, but it is becoming a fast reality of need, they need to deploy these technologies at sufficient scale, because not only that does it support the technology companies themselves, but it produces the evidence needed to validate them and advocate for them at a national level, perhaps.
As you've said, there are a lot of forward-thinking clinicians. There's sector-wide acceptance that change needs to happen. What gives you the greatest hope that health systems will embrace this inevitable shift?
So for sure, there's hope from the clinicians, as you've rightly said. The biggest thing here for me is the patients. It's the patients themselves. The demand is there. The pull that we get from patients, and it's been really interesting for us actually, the pull we had from patients for Aide was fair, like reasonable, demonstrable. The pull we've had from Mirror, which is our AI scribe for patients, has been arguably significantly higher, which is a great signal. I mean, there's no one who hasn't recognized the need for that. The second we talk about Mirror saying, oh, it helps you remember what was discussed in your consultation, so you've got a permanent record of it, everyone goes, oh my God, if only I had that when, or I need to get this to my grandparent or my parent. That has been a striking signal for us. So it's the patients themselves. The NHS's biggest untapped workforce is the patients themselves. And from our measure, they want to be involved in their care. In order to do that, they need good digital tools. And the reality is, I know we've spoken about this, it was in the piece you guys kindly published, which was healthcare just doesn't become sustainable by pushing clinician capacity beyond its limits. That doesn't really serve anyone. It becomes sustainable by designing care that supports the patients in the roles that they are already playing in every single day. We just need a little bit more support.
Absolutely. Ian Wharton, thank you so much for your time.